Hello, my name's Mary, and I'm very grateful for the opportunity to speak for the next 15 minutes or so, and have learned so much already on the webinar this morning and hearing about Charlotte and Vita's research. Love the idea of a learning log from this morning. But moving on to talking about palliative care, and two things I'd like to say to start with. The first is that an awful lot of this work was done by my colleague Sharon Yates, who's here on the call with us, and I'm presenting on behalf of both Sharon and myself and a huge team of people who undertook this work. The second thing to say is that I realized when joining the chat group this morning that I work in a hospice. I've chosen to, and that particularly I'm speaking at this point in time into the fact that lots of people are unwell and lots of people are worried about their families at home. So I hope that this presentation isn't going to be distressing for anybody, but if it is, please do let Hannah know through the questions, or perhaps just mute out for a while. So to talk about what we did and to tell you a little bit about our background, you can see that the slide in front of you has three images. The first out of focus image is the picture of Oxford, which is where we both work. So this, the image to the right is the entrance to the John Radcliffe Hospital. So our trust is an acute hospital. It provides a district general hospital function for the people of Oxford and Oxfordshire. So by that, what I mean is that when I am ill with appendicitis or whatever, I pitch up into the hospital and it looks after me as a local person. It also is very invested in and delivers complex care at both a regional level for the South Central and also for a super regional level. It's further made more complex by the fact that the hospital is spread across 4 sites. And the one that I'm going to talk about today is the John Radcliffe, where the acute care is, as opposed to the cancer care, which is where the hospice is located. So it is a complex system with a very complex geography that you would never have set out to put the hospital across 4 sites. If you come to the picture that says Sobell, that's the front entrance to the hospice. So we are an NHS hospice that is located on the Churchill site, which is a site that has cancer oncology, renal departments, and essentially the oncological surgery, so a colder site than the John Radcliffe, and I'll come back to explain why that's important in a slide or two. We are an NHS hospice, but we have an active charity which supports us to the tune of about 40% of all the money that we need in order to be able to provide a service to the patients of Oxfordshire. So we provide for about 5/6 of the patients in Oxfordshire, and that is an adult service. And if we look at the population of Oxfordshire being roughly 600,000 people a year, then roughly 1% of, not per year, they live there, excuse me. I was rattling on in my head to say that roughly 1%, so roughly 6,000 people die in Oxfordshire each year. And of that, approximately 3,000 die in the acute trust, and Sobell House looks after about 10% of that. And that's really where our journey starts, because there are always things you can do to improve, but I think that the care in the hospice and in the department for the 10% is probably care that is of good quality. Now, that isn't to say we just look after 10% of deaths. We also have a wide community team, but for the sake of this presentation, I'm going to leave all of that to one side and talk about those people who are dying in our trust. So that sort of sets the picture and the context. So those things really, plus some work that was happening nationally, listening to what was going on, and I have both stolen this from David Oliver, who's a consultant who's politically very active and works in Reading, and I've adapted it slightly. And it was work that he started to describe to say that there's something wrong if people are not willing to be cared for as they're dying in our hospitals in this country. And I slightly adapted his phrase and started to Sharon and I started to use it as we began to write some documents for our trust. And I guess, as well as worrying about the level of care in the hospital, it was alongside the reality that we were seeing the care in the community. For the first time in the 20-something years I've worked in this part of the country, in the UK, we were watching the fact that the care in the community was beginning to dip and slip. So that, plus the fact that looking at the numbers, we would be lucky to actually just keep at the 2,500, 3,000 that were dying in the hospital. So all of those things came together to actually spur us on to undertake a quality improvement program. At around about the same time, and everything aligned for us, and we were talking about enablers earlier, I think one of the enablers for us was a large share of good luck. So the first was that Sobell House Hospice charity that I mentioned previously, that give us about 40% of what we need to run each year, had true careful financial management, a pot of money that it had accrued over many years and built and worked to build. And it was looking to see how to actually spend that money well and to spend it on care of the dying in Oxfordshire. So they had money. We had the great good fortune of a new chief executive joining the trust, and of having offered an invitation to him to come and look around the hospice and learn about what we were doing, and essentially to do that before his feet hit the ground and before he got too busy with a process and with the normal running of a trust to agree to come and look around the hospice. So that was also a huge enabler for us, in that we had both the money and he provided the permission for us to actually undertake that quality improvement project. In addition, the charity was supported by an application to Sobell Foundation. So Sobell Foundation is and you can see the two names are similar, they're different organizations. So Michael Sobell was the dot-com millionaire of his day back in the time when telecommunications were at the cutting edge. And as well as giving some money to 2 hospices, one of which is ours, he also set up a foundation, and that trust has some money on offer for projects on an annual basis. We were very lucky to pitch up to the foundation and to walk away without any metrics. They asked us to feedback as to how we were getting on and whether we were doing well. They gave us no outcome metrics, no deliverables, and I think that that was the case because there was trust over many, many years. Sobell House has been in existence for 44 years, and the Sobell family have worked alongside the hospice for that period of time. So I think we were a trusted organisation, and we asked the right people at the right time, and we had the great good fortune that we weren't tasked with any outcome metrics, certainly too early on in our development. So Sharon and I and a couple of others put together a proposal looking as to how we might improve care. And we thought that the ways to do that were directly by seeing more patients, so that we needed to up the number of patients we were seeing. When we started out, we did not know how many patients that we reached who were dying in the trust every year. We do now. So it was about 35%. We're now seeing over 50. We also wanted to identify leaders, and I'll come back to tell you a bit more about that. And we wanted to change the cultural landscape so that the care of the dying became an integral part of core business in our trust. The start was absolutely terrifying. I was a nervous wreck, and absolutely certain that my colleagues, the consultant physicians in the hospital that we were starting in, were not going to be interested in what we were doing. We're going to see it as unnecessary, or even in the worst case scenario, we're going to send us away with our tail between our legs. However, that was not what happened. The end, and I've huge thanks to say to Andy Brogren and to Toby. So it was again more good fortune, where Andy invited us to come to a meeting in London where we heard about human learning systems. And I sat there listening to Toby present and thought, goodness me, we stumbled our way through this. Well, there's a whole literature and framework out there that we could have used with great effect. So to say thank you to both of them. So I just wanted to take you through human learning systems and what it means to me in particular. So the first thing I learned is that and this was actually a genuine revelation, was that providing care to dying patients is very important to healthcare staff. I'd not been certain of that before we started this project. And the couple of examples I have to bring to you is first, the emergency assessment unit, which is where people come into the trust when it's clear that they need a short inpatient spell. When we first started off this project, what is now almost 4 years ago, at that point in time, the emergency assessment unit did not want dying people in it. It was asking, where can they go? We're finished, we're a short stay unit, we don't really want to be involved in this type of care. Sharon in particular identified some key staff in the emergency assessment unit, and those staff just hadn't a clue what they were doing, but took the projects, knew where they wanted to start, and took them and ran with them and made a huge success of them. And that, the emergency assessment unit became an exemplar in our trust for how you might be able to provide good quality care of the dying in a busy emergency unit and a busy ward. We got to the point where actually they would refuse to discharge their dying patients to the wards in our hospital because they believed, and this was true, that they provided exceptional care. They did. Second short example to bring to you is just that of Dying Matters Week. So this is a national week to encourage talk about death and dying, and to, I'll leave it, they have a very good website, but we had huge support from our medical director. The very first week we ran this session and we put some stands with material around the hospital, we had a significant complaint that went on for the whole day. And we went to tell the medical director, who turned around and said, excellent, if you've upset some people, clearly people are hearing your message. So I think one of our enablers was senior superb support, and they stood between us and the complaints. And I'm going to leave the communications department just for the sake of time. The second was learning, and I've put again some examples, which was just beginning to learn about forgotten areas of our hospital, such as the mortuary staff, and how important it was to them that not alone did we care for people when they were alive, but also that we cared for their body after they had died. And that group worked incredibly hard with Sharon to actually work out how to help families have bodies early when they needed early burial, perhaps because of a Muslim or a Greek Orthodox faith, etc. And also some senior supports that we had was from our non-executive directors, who actually helped us think about our teaching and how, when we drew in experts the first year, they said to us very gently, excellent, now next year mix it, and the third year have only your own staff speaking. So we got some great advice. We learned loads. We learned to ask, what do you want to do? How do you want to improve care in your own department? How can we help? And how will we know that we've made a difference? So the systems, just to actually talk about this, and to just say, I think we have now got to a point of cultural change in our hospital. And I think we've got to that because actually everybody sees care of the dying as part of what we deliver. And the patient is at the center in that green bit. That is not to say that we haven't had some explosions and coronal mass ejections when we've upset and trodden people's toes, or they have not wanted to focus on care of the dying. I think for me, another measure of success is that the QUIP model has been fully funded through business case applications, etc. So I think we're at the point where we have managed to, by accident, embed a human learning system approach to care of the dying in our hospital. And just to pay tribute, the minute I saw Toby's model, I thought that's exactly what we did. Our purpose was clear. It was to improve care of the dying, and understanding the system we got by talking, as people have been discussing today, human and relational discussions with people about what do you see that you don't like, what do you see you can improve, co-designing. For some people that was, yep, that's a great idea, off you go. For others, it was hand-holding every single step of the way and helping them get there, and everything in between. We undertook lots of experiments, some failed, some worked. As we gathered our courage and moved away from our very nervous start, we started to look at our governance and how we could embed these systems. So the very last thing that I'll do very quickly is just thinking about dying in these times. And I think that there is huge complexity in care of the dying just at the present. It is nearly 30 years since I remember feeling physically vulnerable to picking up a disease, and that was when HIV epidemic was starting when I worked in Ireland. I think in addition, the additional complexity is that people are bringing themselves to work. They're also taking potentially themselves and an infection home to their families and those they love. So it's a very complex time. I think that the healthcare system has regressed and retrenched to some extent just to the present. It is difficult to be human behind masks and gowns. I think that there is such a focus on infection control and intensive care that there's less experimentation. And there is less learning, I think, particularly when it relates to care of the dying. That perhaps is not the case for some other areas of medicine. However, we still have the skills we acquired to trust our colleagues to be able to find their way through this. And we've learned so much in adopting a human learning system model that I think that we've retained the learning to be able to walk through many departments in our trust.